Welcome to the NCLEX Review, where I help you review all the things you need to know for NCLEX. If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com. So let's talk about the nervous system. And when we're assessing the nervous system, we have various types of neuro assessments. So the first type of assessment is called the Glasgow Coma Scale. And this scale is going to look at things such as eye-opening responses. You're going to be scoring the patient based on how their eyes open. So are they spontaneous? Are they only opening when you are talking to them? Do they only open to pain, like if you do a sternum rub, or do they not open at all? And then they'll get a point for whichever one they fit. The next criteria is the verbal response. So we're looking at, are they oriented to what we're saying, or are they confused? Do they have inappropriate words? Are they incoherent, or do they have none? And again, they're getting points for whichever one of those they hit for. And then we're looking at motor response. So we're looking at, do they obey commands? Do they only have a motor response to localize pain? Do they only withdraw from pain? Do they have flexion to pain? Or do they have extension to pain? Or do they have none? And again, they're getting the points related to which one they score for. So the total for the Glasgow Coma Scale is anywhere from 3 to 15. A score of 1 in each category indicates no performance of the skill. So the lowest is 3. So just remember that it doesn't go to 0. It goes to 3. The next type of assessment is called PERLA. And this is pupils equal, round, reactive to light, and accommodating. We want to remember that the normal pupil size is 3 to 5 millimeters. And the way we're checking this is we're shining a light into the pupil and we're looking to see if they are round, if both sides are equal, if they are, when we say accommodating, do they change size when you shine light, and does both sides do it? That is what we're looking for with that. Then we're looking at color, sensory, motor, and temperature. We're also looking at vital signs. And we want to remember that the level of consciousness is the best indicator of mental status. Also within the nervous system, we can have elevated intracranial pressure. And what we're going to look for with this is something called Cushing's triad. So you can see that right here. Now, the 3 signs of Cushing's triad is going to be hypertension, bradycardia, and a wide pulse pressure. If patients have all 3 of these signs, this is called the Cushing's triad. And this is a sign of elevated intracranial pressure. We also want to look for signs like changes in the level of consciousness, headache, increased blood pressure with widening pulse pressure. That is, a wide pulse pressure is the difference between the diastolic and systolic blood pressure being really far apart and widening. So whatever your top number is, you have 180 up top, which would be very high, right? Hypertension. But on the bottom, say you have something much lower. Like typically when we see 180, we'll also see a high number at the bottom, but it will start, the systolic will start to go up and the diastolic will start to go down and it will become wide. We're also going to look at our nursing interventions. So our priority, most important, so if you get a question about intracranial pressure, is to elevate the head of the bed to 30 degrees to promote drainage from the brain. You also want to keep the body straight. Flexion decreases drainage. You want to maintain proper fluid volumes, set up a quiet environment with minimal sensory stimulation, stool softeners to prevent straining and avoid Valsalva maneuver, and limit suctioning performed. The next type of assessment within the nervous system we can do is the cerebral spinal fluid assessment.
We're looking at things like the color of the spinal fluid. We want normal is to be clear and colorless, and we can look for something called halo sign. This is bloody fluid surrounded by a yellow stain when placed on a white backdrop. So you can see this if you drop a drop of the cerebral spinal fluid onto a white backdrop. You'll see a bloody fluid surrounded by a yellow stain called the halo sign. Also labs, so normally cerebral spinal fluid has little protein and glucose with no red white blood cells and no red blood cells and no microorganisms. So we want to make sure that it doesn't have those types of things or else it's abnormal. Pressure, so the normal pressure is 60 to 150, and the normal volume is 125 to 150 milliliters. So within the nervous system, let's do an anatomy and physiology review. So anatomy of the brain. In the brain, we first have the frontal lobe, and this controls our emotions, judgment, controls motor aspects of speech, primary motor cortex for voluntary muscular activation, and Broca's area for speech. We then have something called the parietal lobe, and this receives fibers with sensory information about touch, temperature, and pain from the other side of the body. It is our spatial perception. We then have the temporal lobe. This is where the auditory information comes in and language comprehension. This is where we have Wernicke's area. We then have the occipital lobe, and this is the center for visual information. We have our cerebellum. This is our coordination of muscular function. We also have our brainstem. In here we have the midbrain, the pons, and the medulla. This is where our respiratory and cardiac centers are, our nerve pathways to the brain. Then we have diencephalon. This is our thalamus, subthalamus, and hypothalamus. So our thalamus integrates and relays sensory information from the face, retina, cochlear, and taste receptors. It interprets sensation of touch, pain, and temperature. Then we have our hypothalamus, which is going to control our autonomic nervous system and neuroendocrine system. It maintains body homeostasis, helps regulate body temperature, regulates our appetite, our thirst center, our sleeping cycle, and controls hormone secretion. So let's talk about the autonomic nervous system. So when we talk about autonomic nervous system, there's really two systems within the autonomic nervous system. So we have our sympathetic, which is our fight or flight, and we have our parasympathetic, which is also known as our rest and digest. So when we have our sympathetic nervous system is stimulated and we're in that fight or flight, we're going to have dilated pupils, increased heart rate and respiratory rate, sweating, epinephrine and norepinephrine is secreted, increased blood pressure, constriction of blood, and abdominal arterioles. So what we can think of is what would happen in our body when we were out in the jungle and we see a lion coming towards us. Think about the way your body would feel, that your heart rate would increase, your breathing would increase. All of that is our sympathetic nervous system. When it comes to the parasympathetic nervous system, you're going to have the opposite, which makes it easier to remember. So we're going to instead have constricted pupils, a lower heart rate and respiratory rate, increased peristalsis, so this is our digestion, the food moving through our digestive tract. Acetylcholine will be secreted. We'll have decreased blood pressure and relaxation of the skin and abdominal arterioles. Okay, so let's talk about the cranial nerve assessment and tests. So cranial nerve number 1 is our olfactory. This is our smell. And in order to test this, we'll use something called a smell test. 2 is our optic nerve. This is our visual acuity. To test this, we will look at the pupils. We'll use a Snellen chart to test visual acuity. This is the chart that when you stand away from the wall and you try to read a line of letters. And also check visual fields. Ocular motor is eye movement. You can remember this with the motor. Ocular is eyes, motor is movement. So we're looking at eye function. We're going to look at pupil constriction and extraocular movements. Extraocular movements, these are our cardinal fields. And this is really if you just hold a pen in front of the patient and move it side to side, up and down, getting these kind of going diagonal across and making sure that their eyes can move in all of those directions. We then have trochlear. So this is our eye function. Again, we're looking at those extraocular movements and the inferior abduction. Trigeminal, so this is sensory of the face and chewing. We can have them clench their teeth or light touch. Abductans, this is the eye function. A lot of these are eye function, and again, doing those extraocular movements. Then we look at 7 is the facial. So this is our facial expression. We'll look at facial movement, eye movement, smile, wrinkling forehead. 8 is acoustic. So we're looking at auditory, balance, and posture, hearing, and Romberg's test. So Romberg's test, this is when you have a patient hold their arms out in front of them with their eyes closed. And what you're looking for is to see if one side drifts. And if it does drift, they would fail that test. Then we have glossopharyngeal, so this is the taste. We'll look for the gag reflex. We have the vagus nerve, which is our cardiac and respiratory reflex. We can have them say ah. Spinal accessory, so strength of the trapezius and sternocleidomastoid muscles, so turning their head or lifting their shoulders. And hypoglossal, this is a motor function of the tongue. We can have them stick out their tongue. So one thing to know with this is we can see that 2, 3, 4 all have to do with eye movement. So you can remember those. So if you get a question about which cranial nerve is related to motor functions of the tongue, you already know that it's not 2, 3, 4, and 6 because those all have to do with eyes. Let's talk about CVA and stroke. So our risk factors include diabetes, atherosclerosis, hypertension, cardiac disease, and transient ischemic attacks. There are different types of strokes. So the first one we have is the anterior cerebral stroke. So this is the lower extremity is more involved than the upper extremities and contralateral hemiparesis and sensory deficits. Then we have a posterior cerebral stroke. So contralateral sensory loss, transient contralateral hemiparesis. And then we have a middle cerebral artery stroke. Upper extremity is more involved than the lower extremity in contralateral sensory loss. You probably will not have to remember all 3 of these and how they present. However, 2 things that you should remember are the 2 types of stroke when it comes to hemorrhagic stroke versus ischemic stroke. So an ischemic stroke is due to the blockage of blood flow, which causes an issue with brain tissue perfusion. Hypertension is common in order to maintain brain perfusion distal to the area of the blockage, and we want to avoid suctioning for greater than 10 seconds to avoid increased intracranial pressure. Our nursing intervention and priority is going to be TPA to be given 3 to 4 hours from the onset of signs and symptoms, and it's contraindicated in thrombocytopenia, uncontrolled hypertension, head trauma within the past 3 months, and major surgery in the past 14 days. So the big thing, again, ischemic stroke is that blockage. So there's some type of clot, something that is blocking the blood flow from reaching the brain. Now, a hemorrhagic stroke is going to be due to a bleed. So you're bleeding in the brain due to blood vessel ruptures. Seizures can occur due to high intracranial pressure and dysphagia. And so our nursing interventions are going to be NPO, neuroassessment, prevent activities that increase intracranial pressure or blood pressure, stool softeners, bed rest with body midline, and anticoagulants are contraindicated because they're bleeding. We don't want to increase that bleeding. All right, let's talk about different types of seizures. So the first type of seizure we're going to talk about is epilepsy. So this is a recurrent seizures due to excessive and sudden discharge of cerebral corticoneurons. We then have tonic-clonic grand mal seizures. So the patient is confused and drowsy about the seizure. It's usually 2 to 5 minutes in length. Then patients can have a absence seizure or petit mal seizure. These are brief, no convulsive contractions, and it may be up to 100 times a day. They can also have something called a simple seizure, which is no loss of consciousness, or they can have a complex seizure, so a brief loss of consciousness with psychomotor changes. Now, this will not be on NCLEX, but just so you guys know, there is a type of seizure that does not show up on an EEG. So if a patient is having a seizure, but it doesn't show on their EEG, but it truly looks like they're having a seizure, they can have psychological seizures, essentially. Some people call them fake seizures, but they're not fake. They're real to the patient. They just aren't having electrical activity in the brain. And this can actually come from a trauma. It can be a trauma response. Just so you can take that into your practice with you, that, it's real for the patient when they're experiencing it, but that's not on here. You don't need to know that for NCLEX. That's my spiel. Okay, so nursing intervention. So our priority: assist the patient to lie down, position them on their side, maintain a patent airway, because remember our ABCs: airway, breathing, circulation, allow for drainage of secretions, and prevent the tongue from occluding the airway. We want to loosen restrictive clothes, give oxygen as needed, record the time and duration of the seizure, never abruptly stop anti-seizure meds. We want to do good oral care to prevent gingival hyperplasia from phenytoin, and use suction after the seizure. And when a patient has a seizure, during most interventions, do not use a tongue blade and allow free movement in a safe environment. So we went over this in the safe environment section. We know our interventions include putting pads on the bed. Maybe you're putting down an incontinence pad in case they do urinate on themselves. If they're on the floor and having a seizure, you're putting their head in your lap or in your hands so they're not smashing it off the floor. We always want to think about those types of things. Let's talk about Wernicke's encephalopathy. So this is due to low thiamine intake, B1, or from severe alcoholism. And this is usually where we see it in practice, because severe alcoholism can cause low absorption of B1. So signs and symptoms that we're looking for are an altered mental status, ocular motor dysfunction, this is eye movement, and ataxia. So let's talk about multiple sclerosis. So multiple sclerosis is a progressive demyelinating disease of the central nervous system, and it's autoimmune. So you have a neuron, and on your neurons, there's this thing called the myelin sheath. It goes around the neuron like that. So what happens is the immune system comes in and for whatever reason decides that it wants to fight off this myelin sheet. And when it does that, it interrupts the connections between the neurons. So that's what it means when it's demyelating, because it is breaking down that myelin sheath. So the signs and symptoms for multiple sclerosis are that they're going to have fluctuating exacerbations. This is with most autoimmune disease. There's usually things like flare-ups. It's always not a constant presentation. There could be changes and fluctuations. It's confirmed with a lumbar puncture, and they're looking for elevated gamma globulin. They also might do a CT, MRI, myelogram, or EEG. These patients can have confusion because the central nervous system can connect to the brain and can have sensory deficits, decreased perception to pain, touch, and temperature. They may have bowel and bladder deficits. They can have spasticity, ataxic gait, weakness, tremors, spasm, paresthesia, vision changes, dysplasia, hyperreflexivia, and a positive Babinski, because we just have to remember all of these are connected through these neurons. Anything that is connected to our central nervous system and our neurons is going to be affected. It just depends what pathway is being attacked at that time. So our nursing interventions, our priority is to protect the patient from injury, assist with frequent bladder and bowel elimination, regular exercise and rest, PT and speech and language may need to be involved, and fluid intake and a low-fat, high-fiber diet. And again, these will be individualized depending on how our patient presents with all of these different symptoms that they could have.
Let's talk about autonomic dysreflexia or hyperreflexia. So this is caused by sympathetic nervous system stimulation after either an injury at the T6 or higher, or a lesion in the high thoracic or cervical cord, or a blockage of the urinary catheter. So signs and symptoms we're going to look for are severe hypertension, sweating above the level of injury or flushing, headaches, bradycardia, piloerection, nausea. Nursing interventions include our priority, so important, is to monitor blood pressure and provide antihypertensive meds if needed. We want to monitor bladder distension, assess for bowel impactation, remove restrictive clothes, and keep the head of the bed at 45 degrees. This is a neurological emergency as it can lead to a hypertensive stroke. All right, now let's talk about meningitis. So this is an inflammation of the meninges of the spinal cord and brain caused by bacteria. So signs and symptoms, we're looking for Wernicke's sign, which is involuntary flexion of the hip and knee when the knee is flexed. There's also Wernicke's sign, which the patient is unable to straighten the leg when it is flexed at the knee and hip. They will have a stiff, tight neck, fever, confusion. Their cerebral spinal fluid will be cloudy with high protein, high white blood cells, and low glucose. Our nursing interventions include the priority is droplet and contact precautions if bacterial, or meningococcal meningitis. We're going to assess for signs of intracranial pressure. We're going to keep the head of the bed at 30 degrees and avoid flexion of the body. We're going to put them on seizure precautions, and we're going to prepare for a lumbar puncture because we want to look at that cerebral spinal fluid. Let's talk about Myasthenia gravis. So this is a neurological disease characterized by muscular weakness. This is because communications between nerve cells and muscles are impaired due to defective nerve impulses. So our signs and symptoms are that it is a progressive disease, decreased muscle membrane acetylcholine receptors. They have severe weakness proximal more than distal to muscles. Their facial, ocular, and bulbar weakness, dysphagia, vision changes, difficulty breathing, possibly life-threatening as respiratory muscle weakness can happen. And they probable use of anticholinesterase drugs for treatment. So our nursing interventions include our priority is going to be deep breathing and coughing. We also may need to suction and have emergency equipment at the bedside, again, because of that respiratory muscle weakness. We want to prevent aspiration, so keeping them in a high Fowler's, especially when they're eating. We want to time exercise activities for when the patient has maximal muscle strength, so muscles are stronger in the morning and then they get weaker at night. So we want to do most of their kind of exercise and activities in the morning. We'll administer anticholinesterase drugs, and we want to avoid stress. So we also are going to compare a myasthenia crisis versus a cholinergic crisis.
So let's look at the difference. So with a myasthenia crisis, it is an acute exacerbation of myasthenia gravis, so what we just talked about. So this is an acute exacerbation, whereas a cholinergic crisis is because there's too much acetylcholine due to an over-medication with an anticholinesterase drug. So we can really see a cholinergic crisis in any patient on an anticholinesterase drug. Myasthenia gravis, we're only seeing in those with myasthenia gravis disease for a myasthenia crisis. All right, so let's look at the signs and symptoms. So for myasthenia crisis, our signs and symptoms are tachycardia, increased respiratory rate, hypertension, shortness of breath, cyanosis, bowel and bladder incontinence, decreased urine output, and no cough or swallow reflex, again, because all those muscles are getting weak. Our signs and symptoms for a cholinergic crisis are cramps, nausea, vomiting, vision changes, pale, muscle twitching, and hypotension. So as we can see, there's actually, these are opposite, right? Because one is having hypertension, the other has hypo. Things that are similar is maybe the cyanosis and pallor. Those are similar. So just some things to keep in mind. But let's look at our nursing interventions. So for myasthenia crisis, our priority is to increase anticholinesterase meds. So we want to increase those. So our nursing priority for a cholinergic crisis is we want to hold the anticholinesterase meds. So again, they're the opposite. And if there is an overdose for cholinergic crisis, the antidote is atropine sulfate. All right, then we have something called an endorphin test. This is used to diagnose myasthenia gravis and differentiate between myasthenia crisis and cholinergic crisis. So to diagnose myasthenia gravis, they'll do the test and it will cause the muscle strength to improve. So when they do this test, Endronium, they're looking to see if muscle strength will improve. For people who have myasthenia gravis, there's going to be no improvement. So it's going to be negative in muscle strength or deterioration in muscle strength. So if we're going to differentiate between myasthenia gravis and cholinergic crisis, if after the endorphin muscle weakness improves, then it's myasthenia gravis, myasthenia crisis. Patient will need more medication. Again, because our priority is to increase those meds. If after administration weakness worsens, then it is a cholinergic crisis. The patient is over-medicated with the anticholinergic meds and needs atropine sulfate. So that's how we can differentiate. Patient is at risk for VFib and cardiac arrest during this test. So keep that in mind. All right, let's talk about Parkinson's disease. So Parkinson's disease is a degenerative disease primarily involved in the basal ganglia. Signs and symptoms we're looking for include bradycardia, resting tremor, monotone speech, impaired postural reflexes, rigidity, loss of inhibitory dopamine, a mask-like affect, drooling and difficulty swallowing, and a shuffled gait. And the ones I underlined are really the ones that when you see a picture of someone with Parkinson's, that's what you're going to really see. Nursing interventions include a soft diet, high in calories, proteins, and fiber. You want to increase fluid intake. Safety measures, are they a fall risk? Implement those safety measures. They might need PT, they might need rehab. We want to avoid foods high in B6 because these can block the effects of some of the medications that we use for Parkinson's disease. And we want to avoid MAOIs because, again, this can have some impairment. It can cause that hypertensive crisis. Bell's palsy, which is recognized as facial paralysis. This is due to lower motor neuron lesion on the C7 that results in paralysis of one side of the face. That's the hallmark sign. Recovery is usually in a couple weeks. It does not affect vision, balance, or extremity motor function. So again, and this can also be a sign of a stroke, right? So that's why we have to do those neuro tests as well. So signs and symptoms, flaccid facial muscle. Nursing interventions include facial muscle exercises, protect the eyes from becoming dry. So we might have to have some artificial tears or wear a patch, provide oral care, and have patients chew on the unaffected side. Then we're going to talk about Guillain-Barré syndrome. So this is a polyneuropathy with progressive muscular weakness. It is an autoimmune disease. It may be triggered by an infection causing neuritis of the cranial and peripheral nerves. You'll also see this is a side effect of some vaccines. It's rare, but it can happen. So signs and symptoms, demyelation of peripheral and cranial nerves, which is similar to MS. MS attacks the myelin sheaths on the central nervous system. Guillain-Barré is the peripheral nervous system. So motor paralysis in ascending pattern. It has a 3% mortality because of respiratory failure, autonomic dysfunction, arrhythmias, blood pressure changes, tachycardia, potential respiratory failure, pain and hypersensitivity. And when they do a cerebral spinal fluid test, they'll see high protein. Next thing we're going to talk about is amyotrophic lateral sclerosis. This is also known as ALS. And this is a degeneration of the motor system with no changes in sensory, autonomic, or mental status. There is no cure. Signs and symptoms include respiratory difficulty at the end of the disease because the respiratory muscles are affected, leading to death, muscle weakness, and dysphagia. Let's now talk about Lou Gehrig's disease. So this is a degenerative disease affecting the upper and lower neurons. Signs and symptoms, usually they have death within 2 to 5 years. You'll see spasticity, hyperreflexia, dysarthria, dysphagia. This is difficulty swallowing. You'll see some autonomic dysfunction in about a third of the patients, but their cognition will remain normal. So different symptoms that we could see for this include Horner's syndrome. So this is the result of another medical condition such as a stroke, tumor, or spinal cord injury. Symptoms include a smaller pupil, drooping eyelid, and little or no sweating on the affective side. We can also have anterior cord syndrome. So this is damage is mainly in the anterior cord, resulting in the loss of motor function and pain and temperature with preservation of a light touch, preoccupation, and position sense. Then we have Brown-Séquard syndrome. So this is a hemisection of the SC resulting in an ipsilateral weakness and loss of position and vibrational sense below the level of the lesion. So this is the spinal cord. I was like, what does that stand for? It's spinal cord. Okay. Basilar skull injury. So signs and symptoms. One main thing that we are looking for is called the battle signs, and this is a bruising behind the ear. Another sign is periorbital hematoma, so raccoon eyes, like 2 black eyes, and cerebral spinal fluid leaking from the nose or ear. Our nursing interventions our priority is to support airway, breathing, circulation. We know that's always our priority. We can do C-spine immobilization. That's when you hold the neck still, don't move the patient, make it so they don't move their neck, and neuromonitoring. All right, so some more on head injuries. We also have concussions. So a concussion happens when there's a jarring of the brain with no loss of consciousness. They might have retrograde amnesia where they can't really remember what happened before or regarding the event. And what we want to do, our intervention, is rest and a light diets are encouraged. And then we have a contusion. This is bruising to the brain, can occur with a subdural or extradural blood collecting. We have a skull fracture. An example is linear, depressed, compound, or comminuted. We have epidural hematoma. This is the most serious hematoma. A hematoma forms quickly. So this is the blood is forming inside of the skull. So due to an arterial bleed, it could be the middle meningeal artery. It forms between the skull and the dura mater. there is a loss of consciousness and the patient may then feel better quickly, where they have a lucid interval followed by a quick decline in mental function. We can also have a subdural hematoma. This is a slow bleed from a venous injury. We can have an intracerebral hemorrhage, which is a blood vessel in the brain ruptures, causing blood to leak inside of the brain. And then we have spinal cord injuries. So this can be a total transection of the cord, would be total loss of sensation, movement, and reflex below the level of the injury. So this is like a complete break. If the injury is between C1 and C8, we can have a quadriplegic. If it's C2 and C3, the injury is usually fatal. And any injury between T1 and L4 can be paraplegia. Any injury C4 or above can lead to respiratory difficulties. So our nursing priorities are going to be, first priority is always assume the spinal cord injury with trauma until it's ruled out. We also want to immobilize the patient on a backboard. Body should be midline with head in neutral position, maintaining a patent airway. We want to log roll the patient if needed to put them onto a stretcher. And again, monitor ABGs to assess respiratory status. In spinal cord immobilization, you'll often hear this called C-spine. You can use this if needed. Again, this is to keep the neck from moving. You're just holding the neck. You're holding the head, keeping the neck. We can do a neuro exam if we're concerned. If there's significant trauma, we want to look at level of consciousness. Are they intoxicated? Do they have another injury? And we can do a spinal exam as well.
If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com.